Welcome to TrialSite News Podcast Series. Today we have Paraic Kenney of KenneyLab.org, which uses genomics, molecular and cellular biology, and genetically engineered mouse models to address important, outstanding questions in the molecular oncology of breast and other solid tumors, with further efforts of using genomic sequencing of local COVID-19 strains in an attempt to assess the virus's origination. So, Doctor, welcome.
Thank you, Adrian. Thank you for having me on.
The pleasure is ours. Before we get started into COVID-19, Dr. Kenney, could you tell us a little bit about yourself? It certainly is impressive that you have your own lab at KenneyLab.org. What got you interested in health and medicine, not to mention research?
So, growing up, I always loved science. I went to finishing up high school. I was trying to decide whether to be a medical doctor or to go become a scientist. And I decided, science really was my first love. So I wanted to go learn as much as I could about all aspects of biology. And, once I finished my undergraduate degree in biochemistry, cancer was, really and still remains a major outstanding problem in the health sciences. So I went and got a PhD at the Institute of Cancer Research in London in the area of the molecular biology of cancer. After that, I moved to the United States and I did postdoctoral training for 6 years in the San Francisco Bay Area. And then thereafter, in 2008, moved to Albert Einstein College of Medicine in New York City, where I ran a breast cancer research lab for about 8 years. And then for the past nearly 5 years now, I've been the director of cancer research at the Cancer Research Laboratories at the Gundersen Health System in La Crosse, Wisconsin.
So on COVID-19 then, when did you first start thinking that this virus was going to be a serious problem?
Well, it started hitting the news in really late December, early January. And, the fear of a global respiratory pathogen has always been there. I'm pretty much outside of that field. Like I said, I'm a cancer researcher, so it's not necessarily the first thing I would think about investigating from a research point of view, but definitely it was on my radar as a potential public health issue. So pretty much for much of early to mid-January, I was aware of it. It was spreading in China at that time. There hadn't been really cases popping up in other countries. So I think there was a lot of hope in a lot of places that it could be contained in China. But, retrospectively looking back, given the number of cases that were popping up in all across China, it was never going to be feasible to contain it there. So yeah, I would say late December, early January, it was on my radar.
So then what was the genesis of the study to better understand COVID-19 strains?
So by the time we started doing this work and thinking about this work, which was in mid-March, several cases had been introduced into the United States at that time. The FDA had approved a clinical assay for testing COVID-19. And that's, I got to say, really the key piece of mitigating this disease is the ability to distinguish positive individuals from negative individuals. So our healthcare system here, led by my colleague, Dr. Steve Callister, introduced that RT-PCR-based test so that we could test our patients. And they've been, made a tremendous effort to get that test on board. We were one of the first institutions in our whole region to get that in place for the benefit of our patients and also for the protection of our staff. And they've worked really hard to date, doing more than 5,000 tests in-house. So once they got that up and running in the cancer lab, we were, everybody was looking out the window and wondering when this COVID-19 outbreak is going to really break and have a major impact on our region. So we were winding down many aspects of the cancer research we were doing to try to figure out how to circle the wagons and protect really what are the key ongoing experiments. And like I mentioned, we have a major interest here in the cancer lab in genome sequencing. So, we were looking at the genome sequencer, which wasn't getting a lot of use for cancer in those days, and wondering whether there's something that we as a research lab can do in our region to try to help to mitigate the spread of this disease, or at least understand its spread. So once my colleagues got a test on board for figuring out patients who were positive, we started getting the samples from them with the approval of our institutional review board here, and we had a crack at sequencing COVID-19, which was something, we had never done for a viral pathogen. We've have pretty extensive experience in sequencing humans, at the exome and whole genome level. And in the end of the day, humans and especially human tumors are really, really complicated. This is a pretty simple virus. It's 29,903 letters long compared to a 3 billion base pair human. So we felt it was probably going to be within our capabilities to do that. And we had a go at it. And pretty soon we were up and running, and we've sequenced about 75 cases so far in our region.
So we know that you have international partners in this endeavor. How did this come about?
So we got into this in, like I said, our background is in cancer research, in complete ignorance of everything, all of the global efforts that were potentially going on in this area. We knew that sequencing the virus was likely going to be important. We figured that being able to do that locally and for a large number of people would help inform healthcare interventions within our region. But pretty soon we became aware of this vast, global effort to sequence COVID-19, and we were, really excited and delighted to dovetail our efforts in with them. So we were, within the United States, I believe, the 15th laboratory to bring genetic testing, genetic sequencing for COVID-19 on stream. Many more have joined since then, and there's now an effort being coordinated by folks at the CDC to wrangle all of the people involved in all of these different institutions and help people to share information efficiently and rapidly drive advances in this area. And that's been professionally and personally and scientifically a very exciting thing to be involved in. And obviously the potential for real-time public health impact is quite apparent.
Well, the nimbleness is amazing to watch.
Well, one of the great things about doing research at Gundersen is we're, very strongly philanthropically supported here. So rather than being in a more traditional American research setting where, you get an idea and you need to write a bunch of grants and wait a while and get some feedback, and maybe you get it, maybe you don't, maybe you need to resubmit. We had the equipment, the resources, and the personnel and the skills, pretty much in place to do something like this, except we were looking in completely the opposite direction. We were used to looking at cancer. So it was relatively straightforward for us, given the amount of resources we had at our disposal, to shift gears pretty quickly. The first couple of weeks were pretty hairy because, we were bringing on, a lot of new analytical approaches. In some ways, we were trying to learn to fly the airplane as we were still building it because COVID-19 cases were popping up in our region. But we got a lot of those technical issues bedded down pretty quickly, and the machine is humming pretty well now. So we're pretty pleased with how things are going so far.
So speaking of, what have you learned thus far about the novel coronavirus SARS-CoV-2?
So you mentioned this international collaboration. So I'll respond to that in a couple of different ways. So we're pretty much a very small cog in this international collaboration of viral epidemiologists and people all over the world who are sequencing and pooling these data. The two main clearinghouses for that is an organization called GISAID based in Germany, which aggregates viral sequences from labs all over the world. And they got their start in doing influenza virus sequencing. And whenever you get a vaccine for the flu, and I hope you and everybody does every year, a lot of the decisions that are made about what goes into that vaccine comes from these kind of surveillance efforts. So they had a ton of computational infrastructure that was perfectly suitable for, aggregating COVID-19 sequencing as well. So they got into that pretty quickly. And we send all of the sequences we develop here to GISAID. So I looked earlier on this week, I think they have about 32,000 COVID-19 sequences from all over the world. And like I said, we've contributed a very, very small fraction of that from our region. So some of the things that have been learned, I think, across the world from this that have been quite important is really understanding how the virus spread from China to all of these other places. With respect to the United States, it seems, there were two major sites of introduction. There was a number of direct introductions from China to the West Coast, pretty much the Pacific Northwest is the United States. and those were direct introductions from China. And then the virus spread from China to Europe and circulated there in countries like England and the United Kingdom and France. And then there were multiple independent introductions to the east coast of the United States. And then being here in Wisconsin, which is pretty much in the middle of the country, we have a pretty good mix of both of these east coast and west coast introductions. So that gives you a global big picture look at how the virus managed to spread from China and, you know, show up on our shores and get around our country and into all of these places where we're now seeing cases. A number of lead investigators in this consortium are now, you know, starting to publish papers. The one I literally just have at my elbow right now is from Nathan Grubau's group in Yale, and it's studies like the one that he just recently put out in Cell really can help provide insight into not just how this virus came to be here, but help get a reality check on some of the interventions that were taken early, and to think, gee, you know, were those worthwhile? Could something else have been done? Is there something we can learn now that we can do better in the future? So I think the United States very early shut down air travel from China, but did keep air travel from Europe open. So I think shutting down travel from China probably did prevent a number of new viral introductions there, but, you know, definitely it was a very westward focused intervention. But it's clear now from the genomic data, we had a ton of viral introductions into the country from the east, so from Europe. And then pretty soon the virus had spread to all 50 states due to internal travel within the United States. So I think for quite a while, the major intervention was blocking travel between China and the United States, but maybe in retrospect, some more focus could have gone to shutting down travel from some of these other types of places. And then, you know, more on a more local scale with the sequencing that we've been doing here, we've been able to document about 14 independent viral introductions to our region. And the Gundersen health system spans an area of southwest Wisconsin, northeast Iowa, and southeastern Minnesota. So we essentially straddle 3 states, all of which have had somewhat different regulatory approaches to helping to mitigate this virus. One of the things that was, you know, most intriguing to us looking at these viral introductions was that the majority of them get snuffed out very early. So you may get a virus coming in and a couple of more cases pop up of individuals sharing that substrain. But by and large, these have been in individuals in the same household. So if somebody gets the virus and, you know, they may give it to their spouse or a child or a parent or somebody else living there, but it hasn't spread very far from most of those introductions. And I think that's a testament to the really hard work people have done in terms of social distancing and the sacrifices that so many people have made in our community to stay at home and not work during this tough time. And then, of course, we see in some cases the converse. So we have an introduction of the virus into maybe a congregate facility like an industry or a nursing home or something like that. And then you tend to have more of a risk of overspill from those situations. So we see essentially the full spectrum. Another thing that was interesting to me is, you know, we have one situation where we've sequenced about 30 different independent viruses from the same substrain. So that allows us to roll up some real numbers and look at the variability of symptoms at presentation in these people. And sort of broadly as a community now, we're thinking as people come back to work about temperature screening and symptom screening and how we can be sure that the employees coming back into our businesses and the people coming into our stores are going to be safe. And there's been a lot of discussion and speculation about whether many of these viral substrains are different. Do they affect people in different ways? Clearly, we have different impacts on people. Some people end up in the ICU, some people die, unfortunately, and some people are asymptomatic. So there's been a considerable amount of speculation about how much of this is down to viral genetics versus people. So we've been able to look in a recent series of 27 cases that we've identified here, so all bearing essentially the same virus. And the phenotypes or the clinical features at presentation were pretty dramatically different. Only about 60% of those people had fever or shortness of breath. And then you get into some of the other symptoms like anosmia, which is a loss of taste and smell or diarrhea and other GI symptoms or sore throat, and you get down to the 20% level for some of those. So I think that just underlines how challenging I think it will be to rely on single interventions like temperature screening, for example. These are not foolproof. They're certainly worth doing, I believe, but we need to have a healthy amount of caution and about the risks that individuals who don't have a fever, for example, may pose in some of these settings. So I think a lot of vigilance will still be called for.
Right. Now, we've heard there are a number of SARS-CoV-2 strains. How many strains of SARS-CoV-2 are there? Are some more potent or dangerous than others?
Yeah, that's a really challenging question to answer. So first of all, how do we define these strains? I mean, we define substrains sort of operationally as ones that have a new genetic mutation that's different from the original strain that was initially sequenced back in Wuhan in early January of this year. So this virus, when it moves from person to person, when it infects somebody, it needs to make billions of copies of itself. And every time it replicates, even though its replication machinery works very, very well for a virus, there's a chance it's going to introduce a spelling mistake at one of those 29,903 letters. What's key from our point of view is every virus that acquires one of these spelling mistakes, as that continues to infect new people, that mistake is heritable. So we can track the patterns of infection by assessing these genetic variants in different strains of the virus. So that's kind of what we mean by substrains. I think from a public health point of view or a clinical medicine point of view, when you think about strains, you're really thinking about something, is there something here that's meaningfully different from a clinical point of view? And I don't think we have any confidence so far that anything like that has emerged. So we really look in our lab, at least, at these genetic variants really just as markers of where this virus has been. They're like just the scars of mistakes during replication rather than something that gives the virus a new property or to either increase or decrease its virulence. So that's where we are right now, in a setting where we don't really have very good therapeutic interventions, although, I think all of us hope that something better will come along. And I think, there's a lot of anticipation that we may get a vaccine at some point. So I think once we've got a new therapeutic intervention of some kind, the genetic sequencing will again become important, because we can think about sequencing the virus in individuals where it's picked up after that therapeutic intervention or vaccine has been introduced. And I think that can help give us some insight pretty quickly into whether there are substrains of the virus that are now clinically important in a meaningful way because they behave differently in interaction with either a vaccine or a treatment. So I guess the short answer is the genetics is really useful right now for understanding patterns of transmission and identifying individuals who are sharing similar transmission chains, but we really don't have any solid data that the individual viruses themselves are very different. We think that much more of the variability in how people respond is likely down to maybe the genetics of the individual who's being infected, or perhaps more likely different aspects of their biology. So what kind of comorbid conditions do they have? Are they older? Right. Are they obese? Do they have hypertension? Do they have chronic kidney disease? So there's an array of different parameters that we and others are assessing.
Now, as the director at Gundersen Health, based on your tests and investigations, have any material strategies changed in relation to COVID-19 treatments?
Not in relation to treatments, but I think this has given us a new string to our bow in terms of what we can do as a healthcare system if and when we get more COVID-19 in our region. So we've been fortunate so far in La Crosse. We've only had, I think, 64 or 65 cases. So unlike the situations that have happened in San Francisco and Seattle and New York City, we have not yet been overwhelmed by cases here. That being said, people did great with social distancing for a long time. Our governors gave us some pretty good restrictions for a while, but all of those are starting to relax. So I think everybody is anticipating that there will be an uptick in infections. And with that brings a risk to healthcare workers in the hospital, as well as individuals in the community. So we have worked out pretty much all of the kinks, we think, in our genome sequencing pipeline, so that if and when that impact does occur to our region, we'll be ready to scale up to pretty high numbers of sequencing. I think we figure we can do 64 cases per week, and that will allow us as a healthcare system, really, to try to track down cases if they're spreading within the hospital and mitigate those very, very early. And I think when we look at other countries and the rates of infection that we've seen in healthcare workers, it's clear that hospitals and hospital systems and healthcare workers can become a nexus for infection. And we would like to think that, this genomic approach could be at least some part in helping to mitigate that.
Absolutely. Now, you mentioned about getting a lot of the kinks out. So how far along is this type of testing and analysis coming across the United States?
Yeah, that's a very good question. So I said we were, I believe, the 15th lab to bring that on stream. And I
Yes.
mentioned there's a CDC consortium now called SPHERES, SPHERES, that's headed up by Duncan McCannell in the Office of Advanced Molecular Diagnostics at CDC. And, they have a weekly call that many of the people who are involved in this area join onto. And I think there's about 400, almost 500 folks, individuals who are signed up to participate in those, representing about 110 different organizations. So this is something that's growing very, very rapidly. There's all kinds of people doing this in all kinds of places across the country, some of them doing it at enormous scale, and some of them, like our team, doing it, at a smaller scale. But so I think it's definitely something that's growing. There's also quite a lot of variation across the system in how much information people have access to about the patients they're sequencing. Many of them are aggregating specimens from public health departments where they may know what state they're from or what county, but maybe not what city, or they may not have access to some of the, potentially important information about the biology of the individual. So what happened with this person? Did they have a fever when they were diagnosed? Were they hospitalized? If they were in hospital, how many days did they spend in hospital? Did they have to go to the ICU? What kind of treatments did they get? And what was the ultimate outcome? So I think there's a lot of potentially very, very important data out there that are probably not being captured in a lot of settings just because of the regulatory environment and some of the issues with transferring specimens between different institutions. And I think that's also one place that, a setting like Gundersen can be quite helpful. So as an integrated healthcare system delivering care in 21 counties straddling 3 states, and with essentially one central focus for diagnostic testing that's co-located with the genomics lab, and a pretty strong IRB that also understands the public health relevance of some of these issues, I think we've been able to figure out how to do some of these things, even though we're working on a smaller scale, in a way that allows us to capture some of these important clinical parameters. And hopefully other institutions across the country will be figuring out how to do some of these as well on a timeline that's useful for individuals currently experiencing the pandemic. Because in the end of the day, when all of this shakes out and the dust settles, I think there's going to be some phenomenal research studies that are going to come out from people who are definitely not me, that will take a global overview of all of this and figure out how it spread and where it spread. But that won't do very much good for the people who are experiencing the disease now and who will experience it in the coming months.
Right. So speaking of, what then do you think are the implications for what have been accomplished thus far?
I think the work that we and others have been doing, I think, should hopefully inspire some others and other institutions to bring some of this technology on stream. I mean, much of the instrumentation that can be used for something like this is already sitting around the country in many labs. And I think if people come to believe that this is important and has public health relevance, I think more people could be motivated to try to, introduce something like this in their institutions. I mean, one of the big challenges is paying for it. And I mentioned that we are, fortunate at Gundersen that we've got, many local donors who believe very strongly in the power of scientific research to inform healthcare issues. And that gave us the ability to be quite nimble at the start of this. But it's hard for me to see a point at any time in this pandemic where, for example, insurance companies are going to be reimbursing for the cost of COVID-19 genetic sequencing. So the burden of it really has to be borne by hopefully some grant funding. I think we're all hoping that some money will be forthcoming from CDC and others who, clearly can foresee the potential for this, so that it will enable people across the country to do some of this at scale, on the condition that they don't hoard the data and that they share it, and in the appropriate ways. And a lot of work is being done and coordinated by those folks I mentioned at CDC to try to make sure that the platforms are available for people to collaborate easily. And, I've been really, really struck, having had no background or interest in viral epidemiology 3 months ago, what a welcoming community this has been, and how many folks have developed such wonderful tools and have worked really hard and, to try to make a difference at this challenging time. It's been really inspirational to see.
Yes, absolutely. So let's shift then real quick. I want to talk to you about Gundersen Health System. You guys have a great reputation. Could you name 3 things that make it stand apart from other researchers?
Well, so it's small. It's small in one sense, but it's big enough in other ways. So we have, as a system, we've got 4 research laboratories: 2 on cancer, 1 on tick-borne diseases, and 1 on rheumatology. And these, reflect a lot of the interests of people in our area and the kind of diseases, that they interact with. So, cancer is big everywhere. Lyme disease is endemic in our region, and as the folks here who've been involved in that research have played, very big roles in bringing on diagnostic testing and developing, vaccines that have now been used in various places across the country and across the world. So we have a very small research footprint, but it is supported very well philanthropically within our system. And I think that, for me, has been one of the real keys of our success at research here. A second aspect is the strong focus on patient-centered research. So we definitely want to be doing research that is looking towards our patients and focusing on our patients. We're never going to have a particle accelerator or something like that. But if there's something we're doing that's healthcare related, there's very strong support within our system for that. We've got, a good number of physicians also on staff that are motivated by research and are willing to collaborate. And I think one of the challenges that people like me have in, when you're in a larger university setting or a medical school, is sometimes it's tough to access physicians or biological samples or specimens from tumors. And, sometimes you can actually, I've learned, accomplish a lot more in a small setting more quickly than can be done in some of these larger settings.
So before we let you go today, any parting words of wisdom for other researchers interested in similar pursuits? Any collaborations for them to consider, and so on and so forth?
Yeah, I think this is one of the greatest challenges of our time, is this COVID-19. I've been a cancer researcher now for 22 years. It's pretty scary. Yeah, 22 years since I started my PhD. We and one other PhD researcher on my team really have jumped into this with both feet. It's been a very interesting and exciting time scientifically. I know that many cancer researchers and all kinds of other researchers across the country have been furloughed, or their labs have been shut down. And I think, this is really a time for some people, if they can and have the interest, to step up and try to do something new and interesting. It's, amazing the shift in focus you get when you stop doing what you've been doing for a very long time and are forced to learn something else quickly. So it's potentially, I think, a very invigorating thing for a lot of people to do. And it makes me think that, maybe I should change focus every couple of years and keep everything fresh. So I encourage more people to get involved.
Absolutely, and we hope more do. Now, for those of you who want to learn more about Dr. Kenney's work, you can find him in La Crosse, Wisconsin at Gundersen Health, and his own lab at kenneylab.org. Once again, thank you so much for taking the time to speak with us. We know you're busy, and we appreciate your time.
Thank you, Adrian.
Pleasure is ours.